Good afternoon. I have no financial disclosure to be made. I'll be talking, my talk basically covers the basic corneal trauma and corneal trauma post-refractive surgery. Why is it important to know about corneal trauma? Because ocular trauma is one of the most important causes of unilateral vision loss, and corneal trauma is the second major cause of corneal blindness. It affects young and active individuals, and since the trauma is unexpected, there is a psychological and economic loss to the patients which we need to keep in mind, because treatment is often long drawn, time consuming and expensive. When the patient comes to you, it's important to start with the history, get to know the mode of the injury, object, time, if any treatment taken any elsewhere, whether the antibiotic prophylaxis and tetanus toxoid prophylaxis has been initiated. When you start with examination, please don't forget to examine the normal eye. Proceed with examination of the normal eye first, followed by the eye which has been affected. Since there is a psychological trauma due to sudden loss of vision, be gentle and show compassion while examining the patient. Important to again assess visual acuity in both the eyes, unaided pinhole when possible. Visual acuity is an important prognostic factor for final visual outcome, also for medico-legal purposes. Document the pupillary reactions. On slit lamp examination, first examine the conjunctiva, see if there is any conjunctival laceration, any subconjunctival hemorrhage, and also be aware of occult lacerations, especially if there is the 360 degrees bullous subconjunctival hemorrhage, hypotony, peaked pupil, or an unusually deep or an unusually shallow anterior chamber. For the corneal tear itself, examine the extent and depth of laceration, look at the configuration of the laceration. If there is any uveal tissue in the wound, look for viability of the uveal tissue, examine if there is any lens matter or vitreous in the wound. And like I already mentioned, if you don't see any obvious tear, do a Seidl's test to look for any occult penetrating injury. This is the ocular trauma classification system which all of us are following. Important to note the type of the injury, grade, the pupil, the presence of the pupillary RAPD and the zone involved. This is important because post-operatively, if some other surgeon is seeing the patient, everybody would know exactly what had happened at the time of trauma. Give a rigid shield to the patient when he comes with a corneal test. Stop all the topical medicines. Start systemic antibiotic prophylaxis. Initiate tetanus prophylaxis. If the corneal tear is less than 2 millimeters and if it is self-sealing, if it is unless it's a child or a mentally challenged individual, it is better to use a bandage contact lens. If it is non-self-sealing or stellate with some tissue loss, but if it's still less than 2 millimeters, you can use a glue, cyanoacrylate glue along with bandage contact lens. If it's more than 2 millimeters or if it's a child, definitive surgery needs to be done. Hydrophilic bandage lenses need to be used. Cyanoacrylate tissue adhesive is basically you use the Vexil sponge, use the back of the Vexil sponge and apply it to the sealing incision. It acts by getting invasion of blood vessels and accelerates the healing process. In wound repair, the primary principle of wound repair is to have a watertight wound and ensure that you have a complete restoration of the structural integrity. The secondary aims would be to avoid any uveal tissue, vitreous incarceration in the wound, remove necrotic tissue debris and remove the foreign bodies. Whenever there is any injury, the corneal topography is completely altered by effect of the injury itself, by effect of the laceration. Then when you suture the cornea, there is effect of the suturing and also the normal wound healing. The effect which happens because of your corneal tear is that there is flattening, generalized flattening of your cornea, which is not desirable. The flattening is more if it's a perpendicular wound compared to a shelving wound, because this shelving wound gapes less. What are the effects of sutures? Sutures basically will have four main effects. They will have compression factors, stocking factors, tissue eversion and tissue inversion. Let's look at the compression factors. How does a suture help in wound healing? It basically causes wound apposition by compressing the tissues within the loop. The area of compression is basically equal to the length of the sutures. Interrupted sutures generate a plane of compression in the tissue contained within the suture loop, and a zone of compression is created which is away from the suture itself. These compression zones have a roughly triangular configuration. It's important to understand this because these these zones of compression should overlap. Only when these zones of compression overlap will you have a watertight wound. When these sutures are, you can see lower down there, the sutures are placed far apart, and because of that there is a high chance of leakage in if you repair it with spaced out sutures. If you take single and interrupted sutures, they produce equal everting and inverting forces, so there is no torque factor generally associated with single interrupted sutures, whereas running sutures can produce torque factors. Hence, only if your corneal tear is limbal, you can use a running suture, but not if it's placed anywhere else on the cornea. Just to talk about some basic concepts in suturing, it's important to use a 10-0 nylon suture. The depth of the suture should be 90%. Try and use a no-touch technique as far as possible. It may not be possible all the time, but it is important to place the suture needle perpendicular to the corneal surface and rotate it along its curve, exiting perpendicular to the surface. Entry and exit of the suture bites should be also at equal tissue depth to prevent wound override of the wound margins. If it's a perpendicular laceration, as you can see to the left, the entry and exit is same at the same depth from the anterior perspective, but however it's an oblique wound, then the entry and exit is similar from the posterior stromal aspect. If you try and make it the same anteriorly, then there will be posterior gaping of the wound. The bites have to be perpendicular and equidistant to the best fit imaginary line, irrespective of the laceration itself. Corneal sutures, if placed oblique, produce tissue torque, and hence important that the suture should be placed perpendicularly. This I just wanted to show this. This patient was sutured elsewhere. You can see that there is a wound gape out here. There is an override of the wound margin. It's a mal-opposed wound, and also the suture knots are not being buried. It's very important that please trim the suture knots and bury them away from the visual axis. If there is a linear corneal tear, like I said, if there is a corneal tear, there is flattening, generalized flattening of the cornea. So you want to try and restore the normal corneal anatomy. So you take peripheral bites, which should be long and should be tight. So this will then steepen the central cornea, and you take small bites in the center, which are not very tight. You just minimally compressive. So this will try and maintain the integrity of the cornea to some extent. If there is an angular corneal tear, you need to suture the angle portion first and then suture the rest of the cornea, because this is also important because it will help in restoring the structural integrity. In a stellate corneal laceration, there are multiple techniques being described. In the multiple interrupted suture technique, it is better to suture the straight arms of the laceration first, followed by the stellate portion, which is then closed last. In spite of that, it is possible that the corneal tear may leak, so you may need to use a bandage contact lens to prevent that. These are techniques which have been described in literature. It's a Eisner method where you make partial thickness incisions and pass purse string sutures. These sutures are then tightened to approximate the apices. This is an Akin method where the sutures pass through the tissue and over the apices. It comes out in the center of the stellate tear. A combination of the three techniques could be used as required. Now, if there is corneoscleral laceration with iris incarceration, just by injecting viscoelastic itself, sometimes the iris can fall back. If that's not possible, if that's not falling back by injecting viscoelastic, you can take either a Sinskey hook or an iris repositor and push the iris back from the wound. Any prolapsed tissue, the question to answer is whether the iris needs to be deposited or not. Any prolapsed tissue for more than 24 hours should be removed ideally if to prevent infection or epithelial ingrowth. But if you find that the iris is healthy, it is not devitalized, if there is no epithelium growing over it, then you can reposit it even after 24 hours. This is an example of an iris which can be reposited. As you can see, it looks healthy. This, on the other hand, as you can see, is already having some epithelial or a fibrous layer over it. It's always better to excise this iris and suture your corneal tear. This is again, it's a fresh injury within 24 hours, but you need to excise this iris because all of the tissue looks devitalized and there is no point in repositing this iris back into the eye. Now coming to corneoscleral lacerations with tissue loss, this was a patient it was a week-old injury. There was no infection in the eye, though it looks like an infective keratitis. There was extensive corneal tissue loss, and tried gluing her a couple of times. It did not work, and hence did a slightly larger patch graft so that it involves the visual axis, and because I was not sure if she'll follow up for a routine keratoplasty. Can you start the video on the right? This patient also, this was the way it presented. Actually, just history of injury. There was no cornea, there was not much signs of infection, there was no lens present there. Just tried and separated, like when you do a therapeutic keratoplasty, tried and then separated, like make an angle there, separate the synechiae, and do a regular primary corneal transplant. You may need to use a large corneoscleral button to close that defect. Also important to explain to the explain prognosis to the patient about vision, because when there is lens extrusion and such extensive corneal tissue loss, the visual prognosis would be very poor. If there is corneoscleral laceration with lens involvement, consider primary lens removal only if the injured lens if there is anterior capsule is injured with free floating lens matter. I think I'll just go quick. This you can see is primary corneal tear suturing. This coming to trauma after refractive surgery, it's important because 20 million patients in the United States and also in India are potential candidates. It's important to know about this topic because most of the patients are young patients. They are undergoing surgery to get rid of spectacles, and they may be having a very active lifestyle. And recognition of these risks and tailoring the choice of surgery is important. This was a study done where porcine eyes were subjected to squash balls fired at realistic game speeds. The RK eyes were ruptured at much lower stresses. In PRK and LASIK eyes, it was found that they did not rupture at different stress from normal eyes, but flap displacement was noted, and hence in LASIK patients that would be a major concern. The risk basically remains lifelong. Up till 100 days, it was found that after 100 days there is no increase in strength.
We need to conclude, Dr. Kavitha.
Okay, so I just show these two, just a minute, just show these two pictures. This was a patient who had macros try on day 3. Since his vision was 6.5, he didn't have much visual symptoms, didn't do anything. But this was a patient trauma post-LASIK, 6 to 8 weeks post-LASIK with macros try and epithelial ingrowth. Along with the repositioning also needed to take the sutures to reposit that. And thank you very much.